Again, like I said, my name is Chris McClanahan. I am a coordinator at the Sim Life Center there at Texas Tech, and also faculty for the School of Nursing, and I'm a graduate of the MSN program here for about 2 years ago, I think.
3.
So, is it 3?
3.
No, it can't be 3.
3 in
Okay,
December.
3 years ago. So me and Elisa graduated together here. It's my pleasure to introduce Kyle Johnson to you. He's going to be presenting today. Kyle got his bachelor's in science from nursing in 2010 from Texas Tech in the traditional undergrad program. He began his career at UMC in the cardiovascular CICU unit immediately following his graduation. Worked there for about 2.5 years. During that time Kyle started seminary at B.H. Carl Theological Institute to pursue his passion in ministry. But after about a year, he felt that he needed to continue his nursing education and decided to come here to Lubbock Christian so he could fulfill both goals at the same time. Kyle graduated here with his master's in 2013 from Lubbock Christian, and had worked very closely with Dr. Long and the Sim Life Center on his project that she's going to present to you today, which has to do with the therapeutic hypothermia, the competency of simulation. And it was kind of a pilot study. It was quite interesting to work with Kyle in setting up his simulations and his scenarios and working with him, and we're writing them to see, as he presents a little bit later, how things would progress for him to get what he needed for his outcomes and things. In June 2013, Kyle was brought on to the faculty there in the undergraduate program at Texas Tech. Originally, he was a faculty associate for us for about a year? About a year, and then he actually became full-time faculty for them after he got his master's, and I think he's just absolutely loving working there. We'll say he is, okay. Kyle presented his topic at the Improvement Sciences Summit at the University of Texas Health Sciences Center in San Antonio in July of this year. So Kyle, come on up.
Is this on? Can everybody hear me? Okay. Well, thank you for the introduction. Like you said, my name is Kyle Johnson, and I just started on faculty in June with Texas Tech Health Sciences Center, and I really had the privilege for about a year to work as a faculty associate, where we really are involved with designing simulation. Not necessarily designing sometimes, but just coordinating it and seeing how many things are run. So can somebody give me an idea of what's the most interesting simulation that you've seen? Anybody? Yes?
Subdural hematoma?
Subdural hematoma. We recently in our acute care class did an unfolding study where we give the students a script about a week before, and then they come in and they think they know what's about to happen, but then the patient that had a subdural hematoma declines very quickly. We started developing some new simulations, and when I started as a faculty associate, my mind was really blown with what you can do with simulation. We've started using standardized patients, which are actors that are hired to they have a script, and they play a role, whether it be the patient or a family member or even a member of the professional team. For instance, one that I heard of right when I started was that a standardized patient was hired to play the role of a doctor. So this lay person was given a script to be a doctor, and in the middle of the simulation, the mannequin codes, and the doctor comes in, and this standardized patient's script was to say to all the nurses running the current code, have y'all not seen the New England Journal of Medicine that recently changed the compression rate to 40 and 2? To see, the sole test was to see if nurses would speak up and say no, or if they would just follow along. And so that started opening my mind of what we could do with simulation, that you can always test something, whether it be communication. We've had mannequins that have looked like they've been abused. We've had mannequins with femurs stuck out of them. As I started, the mannequins can urinate. There are so many things that they can do that when I was a student, that was just beginning to happen. It can measure the depth of their compressions. And so my mind started really opening up to simulation. All this happened while I was in my MSN program here, and I was doing a lot of my literature reviews for research on therapeutic hypothermia. And so as I got closer and closer to the end, I wanted to take my therapeutic hypothermia studies and do something more with them. And so I developed a simulation with them. So what is therapeutic hypothermia? It's designed to improve neurological outcomes post-cardiac arrest. My study was aimed strictly at cardiac arrest. It's starting to be studied a little bit more in neonates and post-brain injury. Mine was limited strictly to cardiac arrest, and I forgot my 2 protocols that I was going to show you, but I'll just tell you about them. So in ACLS, what were you taught as nurses for therapeutic hypothermia? Anybody know what you do at the end of, what you say at the end of the code to pass your checkoff?
A return of spontaneous circulation.
A return of spontaneous circulation and unresponsive, consider therapeutic hypothermia. Is that about what we were taught?
Yeah.
Did anybody get any therapeutic hypothermia topics in their nursing curriculum? Did anybody get any concepts on hypothermia? We all learned about the febrile patient, but did we talk about the hypothermic patient in our curriculum? Whether that be by drowning or whether that be by us inducing it? No. And when I was going throughout my program, that's what I realized. I was able to do a curriculum review of our BSN program, and there's nowhere that is required for a facilitator to discuss the hypothermic patient. We all have to discuss inflammation and infection. We talk a little bit about hypothermia in SIRS and sepsis where the patient becomes cold, but that's about all the exposure that a nurse gets. We know what to expect in the patient with 102 temperature. We don't know what to expect with a patient with a temperature of 95 degrees Fahrenheit. So that's where I started developing this idea that maybe nurses don't really know what we should do with a hypothermic patient, what to expect. We know what to expect in the febrile patient. We know what to expect in a patient with a STEMI. We know, I'm a cardiology background if you can't tell. But we don't know what to expect with hypothermic patients. Physicians, same thing. They're not really taught a lot about hypothermic patients and how the protocols are developed. So if you can tell further down, protocols are not standardized and there's minimal core components. So I say again, cardiac-wise, if you have a patient that's admitted with a myocardial infarction, you know that when they're discharged, they're going to have 4 components for sure, 5 if they get a stent placed, Plavix. They're going to have an ACE inhibitor, they're going to have a beta blocker, a statin, and what am I missing? Aspirin. The simplest one, of course. Cardiac background. OR nurses. I don't know much about OR, but I know that if you don't see a core component saying an antibiotic administered 30 minutes prior to cut time, that should be a question. You should be asking why. So there's not really any standardized core components for therapeutic hypothermia. There's a lot of research that says this is what we should do, and this is what we might include. These people meet this inclusion criteria. These people don't meet these inclusion criteria. But I'm telling you, if I had the protocols right here, which I really meant to bring, I had Covenant Health Systems protocol and UMC Systems protocol, and I had highlighted them. And all the green highlights were the same, all the orange highlights were differences. And between the two, there were tons of differences to all get to the same outcome. And so when I looked at these 2 protocols, I thought of how many nurses work at both places. And in my unit, we had some nurses that worked SICU, which does a lot of their cooling at UMC or at Covenant, and CICU at UMC, where we do a lot of our cooling. And I thought, between these 2, how can a nurse advocate for what's right for the patient? In one facility, it considers post-cardiac catheterization an operation, and that makes them not a candidate for therapeutic hypothermia, versus at the other institution, it specifically says they're not a candidate if they're post-op unless it's only cardiac cath, then they are a candidate. That's a huge difference. So how does a nurse advocate for that? So what I started thinking was maybe each facility, as of now until we develop those core competencies, should be exposed to some sort of competency training. Since we didn't get it in our undergraduate program, we should be exposed to some sort of continuing education. Are you walking into the unit and taking these patients as a new grad? Or are you expected to know this yet? Or are they expecting you to wait a little bit of time to get used to all the different protocols that we do have? This protocol that is at Covenant and UMC, each one of them are 4 pages long. And so when you get into the research, physicians, number 1, don't know the protocols, so they don't order the treatment. Number 2, physicians don't trust their nurses to manage it, because not only do they not know the treatment, we don't know the treatment either. And they have to trust their nurses to do the same, or to advocate for their patient. So the purpose of my simulation was to determine a protocol for hypothermia during cardiac arrest, determine protocol variants between 2 acute care facilities, develop a clinical scenario for testing nurse competency, determine staff competency with therapeutic hypothermia, expose the healthcare team to the expected side effects of hypothermia, encourage nurses to collaborate with other disciplines to avoid adverse effects, and to support facility adoption of using simulation as a method to educate nurses on hypothermia. So a lot of simulation now is really headed towards the interprofessional realm, where we start including pharmacy, physicians, occupational therapy, speech therapy, laboratory, family members. We're starting to get everybody included in these simulations. A few months ago, we did an interprofessional simulation where we involved pharmacy with our junior level students. And it was phenomenal to see the debriefing process with what pharmacists didn't know that nurses knew. They literally thought that we were taught just how to give a medication. That's it. They had no idea that we were taught the mechanism of action and how fast to give it, how slow to give it. And when they start asking these questions as a junior level student, the pharmacists were amazed. And so that was one of the goals of my simulation study, which I was not able to really do in my first study, but I hope I'm able to at some point, is to bring a physician in and see if a physician along with a nurse can identify if this patient meets the criteria for therapeutic hypothermia. Do they agree? When they follow the protocol that's set forth for that institution, can they come to a consensus that yes, this patient does meet criteria versus no, they don't? So one focus that I'm really, instead of diving into what hypothermia is, I'm going to talk to you today a little bit about simulation design, because Chris is going to follow up with what simulation has contributed to nursing and just kind of a general overview of what simulation is. So there's currently no research involving therapeutic hypothermia and simulation. Number one, because there's a 24 to 48 hour time period where we cool down a patient, keep them cool, and warm them back up. So that was one of the challenges of my simulation, was to compress that time period into roughly an hour, because we all know that if you've been through simulation, it's only effective for so long, and then at some point your brain is out the door and you've lost it and you're just overwhelmed and you really don't know what to do next. So part of my challenge was to overcome time. The other part was, in the protocol you're required to have laboratory results every 6 to 8 hours based on the patient. So how do we get live laboratory results? How do we make that seem real? Because a lot of times, what do? You come and you read your scenario, you have a list of labs that have already been determined, and really, maybe you draw another lab or you treat the lab, but you really never see the follow-up in simulation, because usually there's not enough time for that. So how do I make this realistic? And then incorporating common nursing knowledge. I had to design it to where, what do we do at 9 o'clock in the hospital? We give meds. What do we do at 7, 11, and 3 o'clock? Assess vital signs depending on where you're at, sometimes 8, 12, and 4. So I did this on 3 CICU nurses at UMC where I worked, simply because I knew that we were on the same page. That would definitely be a barrier to overcome with other nurses that have vitals due at 8, 12, and 4 or anything like that, but I knew that they were on the same page as I was when it came to the common nursing knowledge of how we take care of a patient in the ICU. So my sample population, it was a very small study. I had 3 nurses come in, and they had about 3.3 year average in the cardiac ICU and a 3.3 average interaction with therapeutic hypothermia. It's not, typically the reason these studies aren't done is because of the likelihood that in Lubbock alone, we might have maybe 20 to 25 patients in a year that are cooled, and to have a good standardized or a good study, they're usually trying to get around 75 to 80 for your sample population. So that's why I pulled back and was like, I can't do anything realistic. I've got to pull back and do simulation, because the numbers that you need to make these more standardized is just phenomenal, and it would take a really long time. And so what I started considering is what do we test? These are CICU nurses. They've been nurses for 3 years, so they have a certain pump at UMC. We do not have that pump in simulation. So am I going to test their pump programming skills? Not so much. Hopefully they've got that. If not, it will probably show, but that's not what I'm looking to test. Am I looking at their capacity to take vitals? Not so much. That's not my goal. What I am looking at is the knowledge of hypothermic pathophysiology. My simulation was designed strictly to test the knowledge of current hypothermia, to see if they picked up on normals versus abnormals. Do they diurese or do they conserve fluid? Do they bleed or do they clot? Do they, what levels do we most commonly have to correct? What level do we not correct 1 hour prior to rewarming, which is potassium? Just to see if they got that common knowledge that we have with hypothermia. And so if you can see here, my simulation design, this was my room the day of simulation, which Chris helped me so much with what this room was going to look like and how I was going to run this scenario. But if you can see, just some ideas for those of you who have been in simulation or who even run simulation, I have notes everywhere. So basically that's the Alceus machine right there in the corner. And I just said use the screen for the vital signs because I could not simulate the correlation between the vital sign monitor and my vital signs. If you look a little bit further right up here, I've got whiteboards whiteboards, marker boards, whatever you want to call them, that were sitting above the pump. So I told the nursing student I told the nurse when they came in, I said, here's a marker. If you want to change your drips, erase it. Write what you want your drip at. I will adjust your art line. I will adjust your parameters according to that. If you have a low lab, just write it. If you have a potassium level of 3 and you want to change that, go up there and hang a bag of potassium. I had a med room available. They went out and got their bag of potassium and literally wrote up there, KCl. Because I'm not testing their knowledge of how to hang a drip on a pump. I'm testing if they get the concept. Same thing for my ventilator. I put my tidal volume, my PEEP, my rate, and that could all be changed because we did have a nurse educator that went in and played the role of the respiratory therapist to get an ABG. So that is one of my screenshots of that. There's a nurse that's in there, Kelly Harris, if any of y'all know her. She was part of my design. And so what happened was the nurse came in and took a report from me, and what I had, if this interests you to run something a little bit more live, is I had blank CBCs, blank BMPs, blank PT INRs, blank ABGs, all with the what do we see, platelets, red blood cell count, white blood count, H&H, and I had them all blank, and I had about 10 of them stacked up of each one, so that if a nurse said, it's time for me to draw a CBC, or I'm concerned about this level, I had a bunch of potassium levels by themselves drawn or printed off. I had a bunch of magnesium levels by themselves printed off, so that if a nurse were to say, I'd like to draw a potassium level randomly, I could literally pencil it in, and then we would have someone run in with the lab. So we were really able to make it seem live, like they got live results back, they got live feedback. As far as the time restraints went, I was able to go over the microphone and say 6 hours have passed, 8 hours have passed, and based on them reviewing the protocol before coming in, they were able to go in and do the different things because they made their plan out at the very beginning of the shift. I told them it's 7:00 p.m. So after they went in and saw that they needed to do Q6 AccuChecks, Q8 CBCs, CMPs, and so when I would say it's currently 2:00, they would look at their plan and they could say, well, it's time for me to draw a set of labs. One of the biggest feedbacks that I got was it'd be really interesting to have a sim clock so that we could have real time versus simulated time, because that was one of the biggest challenges, that they really never knew what time it was. And if you're a student and you've been through simulation, you don't realize sometimes that once you give a medication, we typically make, what do? We make the results happen immediately rather than actually the time effect having to take place. And so that was one interesting thing, which I thought that would be interesting to see developed as a sim clock where we can lapse time and you're able to see real time above there. But that's kind of what I did with my simulation. Here's another one where I have 2 nurses giving report at the end of the shift and reporting off to each other everything that they did. And it was really interesting to see during a report, a lot of these patients are really prone to seizures. And one of them during the middle of it said, well, I gave the Dilantin dose. Maybe I should have checked a Dilantin level. I don't know why I'm supposed to check a Dilantin level, but I think I should check one, because she remembered halfway through the scenario that hypothermia can actually decrease drug metabolism. And so she got it back, and because she had only given one dose, it wasn't toxic yet, but it was planned in my scenario that if she hadn't realized that the patient would have went toxic. And when they woke the patient up, took them off the Versed and the fentanyl and all the drugs keeping them sedated, including the paralytics, the patient would not have a normal neurological response because of dilantin toxicity. However, because they intervened, that wasn't seen. And I told them that at the end. I said, that's the knowledge of hypothermia I was looking for, was to see if you understood that you, with hypothermia, you have decreased metabolism. They frequently checked potassium. What the nurse, Kelly, in the previous picture, she got ready to hang. She had a low potassium 1 hour right before they started to rewarm the patient. And it says in the protocol to not infuse potassium 1 hour before because of the influx back into the cell, back into the cell when they start to rewarm them. And she remembered that, and I said, that's what I was looking for, because if you would have infused potassium, you could have actually seen some cardiac arrhythmias. There's lots of different things with hypothermia that throughout this I realized that we aren't trained on in the undergraduate program. I wasn't trained on it really 1.5 years into my time in CI. I was kind of thrown into it, and it turned out to be a really interesting thing for me. So that night I spent most of my time researching things. But how can a nurse from one facility to the other really know what to expect and know what protocol, or other than following the protocol, how can they know what's safe for their patient if they don't have a standard to compare it to? Because like I said at the beginning, we all know right now if a patient's not discharged on a beta blocker or the physician didn't write it for an acute MI, that we better be calling and asking. So what do we call and ask for as a nurse when we have a patient that's hypothermic? Do we know to call and ask for that? And so one thing I was able to do is make the patient urinate a lot during the simulation. And because of my time lapse, it seemed like it was a small amount, but really it was supposed to be a large amount. And that was one thing I wasn't really thinking about, because they're supposed to diurese a whole lot. And one of the nurses stopped, and it was one of the ones that had never had any hypothermia experience, and she said, "Is this patient diuresing a lot or a little? Because I don't know what my time is right now." And I said, "It's a lot." And she said, "I don't know if this is supposed to be happening." So she called the physician during the middle, and she said, "I'm just not really comfortable with this. I'm new. Is this patient supposed to be diuresing, or are they supposed to be holding on?" And the physician did some education. That was me. And so in the future, I would actually like to have a physician sitting in that chair to see if he's able to respond to, a cardiologist preferably, to see if he's able to respond in the right manner and make it more of an interdisciplinary approach. But simulation has really opened my eyes to what you can test, and the fact that even though you might be testing something for 48 hours, you can in fact bring it down to a 1 hour time period. My biggest feedback was the time clock, and that a nurse would need to be sound with IV drips. Other than that, they felt like it was a good form of education to expose the norms. That, like I said, my whole goal was to expose to the norms of therapeutic hypothermia. My results, like I said, I only had 3. I had 3 people that participated. The very first blue line is their pre-test, and the post-test is the red line. I did find that there was some error on my part. I tested a few things I tested a few things on the post-test that I really didn't address. It was more common knowledge based on that protocol, more so than knowledge of hypothermia itself. This was one of my first research projects, so definitely some different things for the next time, but it was really interesting to see questions 2 and 11 were directly addressed in the, 11, maybe it was 11, 1 and 11 were directly addressed in the simulation, and they improved dramatically because of the intervention. And so some of the conclusions that I was able to draw was that it's beneficial for experienced nurses. It helped reveal expected trends during hypothermia. One other feedback was to set up the Alceus machine. If you've ever set up an Alceus machine, you know that sometimes it can be a pretty time frustrating thing. It seems to just always malfunction in some form or fashion. and then improve simulating a 24-hour time. And a new researcher's realization is that more time is needed. I would say that from the time we started on this in January, right, Dr. Long? And I finished the simulation in May, and I probably could have used about another year to be. I mean, I think even at the end of the year, I could have probably said I could use more time. You can and that's what I've realized is that it's a never-ending process when it comes to research, in that there's always something that can be improved on. There's always something that can be changed to make this more realistic for simulation, more lifelike in simulation, and to contribute more to competency. I'd love to have a larger sample size the next time to really see the impact that it has on a group. I'd like to get some of Covenant's students, or Covenant's ICU nurses, UMC's ICU nurses, and Lubbock Heart's ICU nurses, and really see how they interact. If I could formulate a design somehow where there's one standardized protocol that they all follow, and see how they pick up on the trends, and if they advocate for the patient that's diuresing or is having seizures or anything like that. And that, once again, my survey needed to reflect knowledge gained from the experience rather than general knowledge. I think that over time I will learn that probably way before I started, I should have developed some of my test questions and what I wanted to test, and hindsight's 2020. And so it's a learning process, and that's what LCU has ingrained in me from the very beginning, is that it's a learning process and it's a journey, and that as we progress throughout our nursing career, there's always something new to learn, and that when you're given a task, you can always accomplish it. So if some of you, how many of y'all are in the MSN program right now? Anybody? The BSN program? So as you're going throughout, when you're in your research class, which I feel like everybody always dreads for some reason, you really, I don't know why, but everybody's like, oh, I'm about to take research. Find something that's interesting. And, because when I walked into it, I was a little nervous about it. I was like, what am I going to do with this? Find something that's interesting. Don't just go into the literature and find something that's really hot topic right now and just say, I'll do my research on it. Because as I found out, this is something I would like to carry forward. And as I've said before to other people, the last thing you want to do is spend 3 or 4 years of your life researching something that doesn't interest you. So this was something right off the bat. The first night that I got thrown into this was really interesting to me. I said, I don't know anything about hypothermia. How do they expect me to take care of this patient? And then to come out to find out it's kind of a national phenomenon, that a lot of nurses feel that way when they get thrown into it. A lot of physicians feel that way when they get thrown into hypothermia. And so find something that interests you and do something with it that you're passionate about. And I would have never imagined that I could develop something like that, but with Dr. Long's help and the SimLife Center, they brought my idea to life, and it was really phenomenal to sit back and watch simulation that we wrote and we worked on, and watch it come to life in a simulated setting. I feel like in the future we'll start seeing core measures for therapeutic hypothermia where you do know what to expect, and you do know this patient should have this, this, and this on board. They should be cooled down, and right now it's in the literature between 4 and 6 hours. That's a lot of time, and there's a lot of literature gaps as far as how long we cool them down. There's no standard on that. Australia says, hold on, we gotta get those backwards. Australia says 12 hours. Europe says 24, no, Europe says 12 hours, Australia says 24 hours, and American Heart Association says 12 to 24 hours. So, that's a lot of time. So there are timing methods or timing tests that are currently in progress, but I think that as nurses right now, we will see that goal time developed in our lives. And that at some point, competency training, they say it a lot of times now, that at some point simulation may be part of the NCLEX, where students are being tested live with a fresh scenario, and they have to, I know I'm seeing lots of eyes right now like, what? But it's very true. How can nurses act under pressure? How can they act with a team? Tomorrow we're doing something at Texas Tech called the Quality Enhancement Plan, where in the afternoon we will have physicians, nurses, occupational therapists, speech therapists, clinical laboratory science all sitting around with one scenario, figuring out each part and each role that each person plays when it comes to basically patient outcomes for this person. So not really a simulation, but a case study where we start learning who contributes to that person's care. And I really do think at some point we will see simulation as part of, you got to get out of nursing school, you got to pass simulation to get out of nursing school. It's currently part of our transitions course, which is our last course. You have to pass 3 simulations. Prioritization, and I can't remember the other 2 in skills. You have to pass those 3 simulations to go on to be a candidate for graduation. And so I feel like it's heading in that realm. And right now, UMC and Covenant, I know, do a lot of their continuing education with the Sim Life Center and the Sim Center that they have at Covenant. You're required to go through, what are those called? Your annual competencies, where you come in and you're expected to identify all the errors in the room, or you're expected to run a mega code and adapt and figure out, it's part of your ACLS checkoffs. And they're using simulation more and more. And this is just one realm where we were able to crunch time into a small window of time and make things seem a little bit more realistic, a little bit more alive. And I think that what you as BSN students and future MSN students will see is that simulation is going to be used for a lot of different things. And I think it's interesting. And I hope, if you have any questions about simulation, I know that Chris is going to talk about some things, but if you have questions about hypothermia or anything like that, I'm more than willing to answer any questions. I know I didn't dive into the patho of hypothermia, but y'all have all been through those lectures before. So I wanted to talk to you about what I did in sim, and I think that the ideas are endless when it comes to simulation. And people say that it's not realistic, and some people are on the opposing side. But I'll never forget sitting in our simulation lecture that I came on to tech as, and they said, show us one article that says that clinical works. I want to say that Sharon Decker said that. Show us one article that says that clinical works. I can show you a ton that says simulation works. And I thought, wow, because and now that I'm on the other side, I hated simulation when I was in nursing school, I'll be completely honest, it scared me to death. But sitting on the other side, we can see brains work. And that is the coolest part of simulation, is you can see, and now they have goggles where they can put them on people and really see what they're cueing in on. You can see where their eyes are focused on. And I think that's phenomenal that we can see that much with sim. Is what are they focusing on? What are they looking at? Why are they just standing there? Because that's what they used to think when I was there. Why is he just standing there? Usually because I was looking at something or trying to figure out what are they wanting me to do. But why were you focusing on that blood pressure for 20 seconds? If we could ask that, just amazing the endless possibilities that simulation has. If you want a list of references, I have them available. I hope that I've made sense of some things, and I hope that simulation is interesting to you, because I really feel like it will be used throughout our nursing careers. Thank you.
So I have one question to ask everybody. How many of you have experience with simulation? Okay. Describe to me what type of experience did you have with simulation?
All through nursing school, we did simulation all the time, but code blues and everything we did in some.
So through nursing school, but code blues mainly. Anything else?
Just how to treat your patient,
Okay.
everything we did in some.
All right. Patient treatment. Who else has had some simulation experience? All right. Well, I'm not going to ask you. I know what your responsibility. Anyone else? Yes.
We have our annual ICU competency every year done in the sim lab, where we run our adult mega codes, and then in nursing school we had a sim lab.
So, thinking about simulation, I asked that question. The next question I want to ask you guys is, when I say the word simulation, what does that mean to you? Maybe simulated learning environment, simulating real life, okay? That's what happens in simulation. I was going to steal Kyle's presentation there a minute, his pictures of the rooms and stuff. You notice when you looked at those photographs a minute ago, the environment is as close to real as possible. okay? We can't create it completely. We can get very close, all right? The other fun things about it is simulation is an emerging field when it comes to medicine, but it's been out there for a long time. All right, it's been out there since the beginning of the military. They've always done simulation to figure out how to beat somebody at their game. The airlines have done it for years and years and years for safety, okay? But when it comes to medicine, it's really growing, and it's growing quite fast, okay? When you look at that environment, I can't buy anything as a coordinator of the sim center. I can't buy anything for that simulation center that's fake, other than the mannequin, the patient, right? I have to use real pumps. I can't buy a fake pump. I can't buy fake IVs. I can't buy fake dressings. I have to buy the real things, okay? So you're using the real equipment, okay? When we use standardized patients, like Kyle said earlier, when we have paid actors that come in and play the part of those patients, I can use a real patient. I can take Sim Man out of his room because he has a Wi-Fi connection with his patient monitor, and I can simulate the patient's vital signs. So I can give him a blood pressure that's a little low, right? And then tell him how to act a little loopy or something like that, so he's having some hypovolemia issues, or maybe it's a diabetic issue, things like that. So we can use standardized patients. We can use the mannequins. The mannequins that you saw, they're the one that Kyle was using. They run about $85,000 to $100,000 per mannequin. Okay, they're very expensive to buy, but they're integrated. Like he said, they can urinate, they can sweat, they can tear, froth at the mouth, things like that. Simulation is growing so rapidly with medicine, and the technology is growing so quickly that, as Kyle said earlier, it's no longer that we just go in there and we teach you how to take care of your patient, okay? We're teaching you didactically pathophysiology and the things that are going on with the patient. We're teaching you signs and symptoms, okay? We're going to start teaching your medications, and you get these things through pharmacology class, you get it through healthy aging class, you get it through acute care and chronic care courses, things like that, right? And then they send you to clinicals, and you have to put it all together in your head in the middle of clinical. Well, instead of doing it with the patient, you can actually do it with the mannequin. We can simulate the vital signs, we can simulate the problems, we can moulage them, do things like that, make them look like they have wounds and sores and everything else on them. It gives you a chance to grow as a nurse and change from critical thinking to clinical reasoning and critical reasoning, okay, instead of just critical thinking, okay? These things are changing. It's emerging this quickly. How quick is it changing? It's changing fast enough that I can't keep up with the technologies, right? How many, we're up to what, iPhone 5Cs and S's and whatever else now, correct? Okay. We're doing research in the sim lab, looking at using not just your iPhones, but iPads, where you as a nurse goes into the patient's room and the patient goes, I don't understand my disease, can you tell me more about it? You know what, I can show you. Here's an article, this is what they're doing, this is why we're giving you this medication, because they tested it on 25,000 people, it shows to be more beneficial, blah, 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 blah. They're not learning about it on the news, they're learning about it from their healthcare provider, which is their professional, that means something to them. Okay, I see a med that's on the news, and all I think is money, 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 come buy my stuff, not the fact that it's beneficial. It becomes beneficial when me as the professional starts teaching this person those things. So we're using iPads where they can look up their patient information, education, things like that. How about access to the information that you need? How cool would it be to be able to have your iPad there in your room that you keep now? Now as a nurse, you carry around an iPad, and when you need to look up your patient's labs, you pull it out, you look up the current lab, you hit the button, refresh. There's the most current labs. The physician can flip over and look at the x-rays and the CTs and decide, yes, it is a pneumothorax, we need to go ahead and put a chest tube in, okay? Look at those things. They start this technology, and it happens right there in the patient's room or just outside the door. We're not running up and down the halls all the time to get our information. We're charting real time in the patient's room. We're looking at that information, and we don't have to necessarily push around that big, what do they want to call, what do you almost say they call them cows, now they're wows, now they're whoopie-doos, or whatever it is, BMWs, yes.
Cows in room 4 didn't go over well when they heard it outside of the curtain.
Oh. Yeah, so instead of pushing these big computers around, you're using the iPad technology. Think about other things that we can teach you as healthcare providers, okay? These mannequins come in ethnic skin tones now, all right? And when we're giving tours of the SIM Center, I always like to go, I'll take you in and show you SIM Mom, our birthing mannequin. She delivers a baby, okay? She's Caucasian colored, you know. Well, this particular mannequin requires somebody to be a puppeteer, meaning we're gonna push the baby out. We wanna control how that baby comes out, so we can do shoulder distortions, we can do other things that we couldn't before. But I tell everybody, I want this baby in Hispanic and African American skin tone. Why? Because I'm dad, Even though I'm pushing the baby out, I'm going to play the part of dad as the instructor or the compassionate husband right there at the side as she's delivering. I'm pushing this baby out, and guess what? My baby comes out African American. She's Caucasian and I'm Caucasian. What just happened? Okay. Something happened 9 months ago, and it's a bad joke, but what am I trying to teach? I'm trying to teach care of that patient, trying to teach care of that mother, but now in the scenario the way I've designed it, I get physically violent with mom because of the infidelity. How many of you guys have been through de-escalation training or training on how to handle a violent patient in your rooms? Is that taught in normal nursing school? Okay, we can teach community issues, we can teach behavioral health issues, we can teach medicine, pharmacology, psychology. We can teach through all the disciplines. We can work together as groups with those disciplines. But now I can teach you things that you would have to go out and learn in real life when it happens to you. And you don't see it's a code orange. We got violent people. I can't remember what it is that we're covering, But we can teach these things now. We can teach disaster situations. Sim Man he's completely wireless, except for one tube that drains fluids out of his arm. We can stab him up, make him look like a burn victim or whatever we want to, take him outside, put him under the trees, and he still breathes and does all his stuff. And we'll call EMS just to see what they do and how they treat him. Okay. The other thing that simulation can do is that educational component. But you can use simulation as quality improvement. All right? You notice it seems like every time you turn around, Covenant's building a new part of their building or changing a wing. UMC's doing the same thing all the time. But how do you know how well patient flow is going to be through that hospital? How well do you know that you're going to identify issues with where the nurse's station is and the med station is in a critical situation? You can use simulation to find QI issues, things like that. Kyle said earlier too, talking about to get out of nursing school, you're going to have to start passing simulation things. What about pre-employment? Okay, I've got nursing facilities right now or hospitals right now that call me saying, do you write scenarios for pre-employment so that we can take a first-year student right out of school, and they also want scenarios for those that are more seasoned to be able to say, you haven't worked in nursing for about 4 years in a hospital environment, maybe you did school nursing or something like that. We need to make sure you're competent before we hire you, so you're going to have to pass 3 scenarios of different types to make it through there. These things are changing, okay? You're going to be using simulation just to be able to get your jobs now before too long, okay? Standards with simulation. How fast is it going? June of this year, ANAXL actually released the first set of standards when it comes to simulation, clinical simulation. Okay. So if you talk about the people that work at the Sim Center and the simulation technicians, the coordinators, the staff nurse, things like that, the titles, what about the simple things of titles? Okay. You guys had the discussion yet about why nurses have so many initials behind the back of their name? Because we all have to be special and have our own little special niche in nursing, correct? Okay. Those titles aren't even standard. There's 4 names for the simulation technician, and his job is just to make sure the equipment's working well. Okay. Sim tech, sim specialist, simulationists, and sim technician. So sim tech, sim technician. 4 names for the same job. How confusing can this be? The standards are just now coming out. So you guys, as you get out there and have a chance to use simulation and work with it, you have a chance to also start writing and helping produce these new standards and how things are going to change. Okay. Talked about kind of how fast we're going, talked about the standards and things being out there. What in simulation, other than the costs of things like that, what hesitates you guys to get into simulation or use simulation anywhere? Because I know every one of you, even though some of you didn't raise your hand, have used simulation at some point. How many have taken ACLS in the last 2 years? I would hope everybody raised their hand because that's as long as you get to go, right? Okay. If you've had ACLS, you've used simulation. It means just using the mannequin and pushing and doing your skills. That is still parts of simulation. It includes the case studies. It includes roundtable discussions and things like that. Okay. What holds you guys back from getting into simulation?
Someone monitoring you and evaluating you.
Oh, it's scary. It's scary knowing somebody's behind a one-way mirror. It's scary knowing that there's 2 or 3 cameras on you and that they're listening to you like the voice of God, and they're waiting for you to make your mistake. I understand that. If you notice in that first picture that Kyle had up there of the environment, there was a little camera kind of off to the side. Okay, our rooms there have 2 cameras in the rooms, but because of the amount of equipment and stuff that he was doing in there, we had to put in some extra cameras in there. It adds some uneasiness, and I understand that. But take the camera components away, and I say this, in Southern California, the United States, well, the military in a whole, but the Marines more than anybody else, actually have a simulated city out in the desert that looks like Afghanistan. The buildings look like Afghanistan and stuff. It's about 3/4 of a mile long from one. About simulation like Kyle was doing, being intensive. Imagine being a medevac group that has to get from one end of that town to the other end of town, under fire, taking care of patients and casualties along the way, and they have to extract them to the helicopters on the other side. These guys are actually doing things with people shooting at them, real explosives going off around them. They hire their standardized patients that already have leg amputees and arm amputees, and they have a big explosion, and this guy happened to be the one in the Humvee. Now he's missing an arm that's bleeding and a leg that's bleeding, and they treat them. It's different when you have your mannequin provide a little bit of return to you and talk and stuff, and it's a whole other thing when you really have somebody missing a leg and he's screaming and hollering at you in pain and things like that. Okay? How do you handle stress? How do you handle emergency environments? These are the things simulations are doing for us. Can I answer any questions? Can Kyle answer any questions for you?
Chris,
Yes.
have any of the accrediting bodies for schools of nursing come out with recommendations on substitution for clinical experiences using simulation?
No, they have not. That is still in debate. At Tech, we kind of use a 2-to-1 rule for 2 hours of clinical, you get 1 hour, or 2 hours of simulation, you get 1 hour of clinical, I think. That's not there. The Board of Nursing does not have anything out there. Nobody's recognizing or showing the standard yet as to what it is. That's something that we still have to research and see what's beneficial if you're getting that same education out of that time period. I wish I could say there was, but there's not. You guys are a quiet bunch.
Let's give a big round of applause to these gentlemen.